The Cure SMA meeting has highlighted many of the wonderful advances that have occurred in treatment of SMA, the ones that are clinically approved, as well as potentially novel therapies that are in the pipeline with combination therapy targeting different sites, SMN modifying therapies plus muscle target, for example. Despite these advances, the access to therapy is not universal, and the speed of which we can identify the early identification, even in the United States, is not uniform, as not all states have newborn screening that is operational at present. Many have approved it, but it's still being processed. So that causes challenges to clinicians. One of the challenges with identification has to do with speed of access to SMA gene testing. In the United States, that has improved dramatically, and now we have access to those testings that are even free of charge with a rapid turnover so that treatment can begin expeditiously. That degree of access to the genetic testing is not universal. And in other parts of the world, especially parts of the world that aren't as industrialized, that may be quite difficult to achieve and can have to be done based on clinical situations, which is less than ideal and oftentimes not what is allowed to start with treatment. When we deal with newborn screening, there are differences with how fast the investigator is alerted and how fast they can access medication depending on the insurance, depending on where you are in the country, whether there's even insurance for that baby, and how fast that insurance is processed. And those delays can cause harm, especially in the SMN2 copy number. Later on, there are delays, even with symptomatic, in terms of being allowed to treat a child, for example, with risdiplam, who does not conform to what has been published in clinical trials. And that is oftentimes seen across the board. We see this with newer medications a little more so than with those that are established. Then it's a growing curve, at least in the US, with regards to um, al- the insurance companies having a familiarity with the medications that we are using. We still have difficulty with transitioning medications when we believe one medication may not be working as well, trying to get that second medication approved. And oftentimes that has proven quite difficult, even though there are big differences between two medications, and still you have to prove why you have to use the second medication. At an international level, it is more of a problem because oftentimes there is no access or timely access to specific medications. I know that it is increasingly being approved in, for example, South America and in Asia, but it is not uniform by any stretch of the imagination and is impossible to access in some countries. The hope is that it would be universally available newborn screening and that we are able to identify all children before they become symptomatic and treat them in a timely fashion. And then we wouldn't have to have this dichotomy between those identified pre-symptomatically who have a very bright future, as opposed to those treated symptomatically, which, depending on how advanced their disease is, are going to have greater burden to find recovery. And the other topic in that regard is with regards to gene transfer therapy. The gene transfer therapy is very effective when it's used early, and the younger they are, the better it works. In later, more symptomatic patients, it's not as effective and may even have higher side effects because the number of vector genomes that needs to be administered, which is weight based, is much greater, and the side effects greater as well, and the likelihood of improvement less easy to obtain. So early treatment in those cases is of the utmost importance. When it comes to newborn screening, I have made a big plea for people to take into consideration the nurture and the sprint data showing how those SMN2 copy numbers of 2 are a very different population who can't afford to wait days as opposed to the SMN2 copy number of 3. So it's important then to treat as early as you can, not delay at all. And if there's any specific item, laboratory test, for example, AAV9 titers or troponin elevations, or something that you would need to wait in order to administer, for example, a gene transfer therapy, that you should be proactive and offer a gap treatment. For example, now we have nusinersen, so a gap treatment of loading until the time where those side effects diminish, or if they don't diminish, then you can choose to switch to an oral medication that would be approved after 2 months of age. So, no delays, bridge with another medication if needed for those with two SMN2 copy numbers.